Welcome to today's episode of HIPcast. We are excited today to bring a new guest, I suppose I should say, to this show, but not a new health information professional, Anneleah Williams-Bridges. Anneleah, welcome.
Thank you, Shannon. I'm happy to be here.
Yeah, very good. I'm going to read your bio, and then we're going to get into some questions. Today, we're going to talk a little bit about, first of all, of course, your health information journey. That's important to us as professionals to know where folks come from, how they got here. Then we're going to talk about a couple of topics that could be contentious in the minds of health information professionals. We'll talk about, do clinicians, nurses, clinical staff belong in health information management in our profession? And we'll talk about onshore versus offshore coding and revenue cycle management if you're outsourcing. So I think that Anneleah is probably going to teach me some things and maybe have my viewpoints opened up, have my mind open to some new viewpoints. And then at the end of the day, the health information management profession will still be intact. And I trust that is going to be the case forever and ever. Amen. So Anneleah Williams-Bridges, MS, MBCA, RHIA, CCS, CCSP, CCDS, RHCBS, licensed in health insurance and managed care, experienced innovative healthcare executive that is data-driven with a proven track record in performance improvement, revenue cycle optimization, and change management. Anneleah has a uniquely diverse background with strong foundational experience in both professional and hospital settings with almost 20 years of successful leadership experience. Her career in healthcare started in quality assurance and compliance for third-party payers. With knowledge of health insurance and Medicare and Medicaid claims processing, Anneleah offers invaluable insight on coding compliance, CDI, reimbursement methodologies, regulations, and practices in perspective to facilities and practices. She has also served as a national consultant, assisting organizations across the nation in implementation of revenue enhancement programs. Anneleah has earned recognition in the industry as an educator on best practices, CDI, hospital and professional coding compliance, revenue integrity, physician education, and quality assurance. She's an active member of AAPC, AHIMA, ACDIS, ArchPro, the Virginia Health Information Management Association, and NAMAS. Anneleah has exemplary leadership experience and has led external and internal auditing, coding, CDI, rev cycle, and educational teams. Anneleah has supported organizations in growth and operational improvement in various settings such as level 1 trauma centers, academic centers, health systems, community hospitals, critical access and rural clinics, the VA, physicians' practices, and long-term care. So, Anneleah, I will say your diverse experience is only matched by your diversity in membership in multiple organizations and credentials behind your name.
Very true. Very true. I usually come with a long train behind my name.
I was thinking you need a hobby.
Great statement.
That's a lot. So yeah, it's very exciting to have you here and excited to learn from you today, as Shannan mentioned. So one of the things that we always like to ask folks is about their journey, as many of our listeners are students or new professionals or folks that are 20, 30 years into their profession, or even folks that are retired. But it's always a fascinating thing to learn from somebody's journey. How in the world did you end up in the HI profession? A lot of the stories that we've heard are funny and crazy, and it's, a lot of us it's fascinating how a lot of us have a very similar story of how we found the HI profession. So tell us, how did you find this?
Well, I want to say maybe starting out, it started as early as doing data entry for my dad. He had me do his bookkeeping at an early age, and I loved the devil in the details and just the tedious work. So when I got older and I came across a catalog for medical billing and coding, I thought, this is similar work and it sounds tedious enough and like it's something I would enjoy. I think all health information professionals, we have our quirks about us, and that was mine, just the redundancy, the details. And so I ended up taking classes toward medical billing and coding, became certified, and then from there, I just had just a thirst and appetite for learning more, and how can I learn everything I need to know about medical billing and coding, and then revenue cycle. And then over the years, I've come to find that it's all interrelated and that it all serves one big picture. And that's how I became a health information professional.
Yeah. Are you at liberty to say what your dad's business was?
He was actually he was in video production. So he had a very successful production company in Chicago, Illinois. So, yeah.
And doing the books for that, I need to get my kids to start doing the taxes here at the house or something.
Start them early.
Put them to work. I do charge them rent. That's always a fun story. My girls are 12 and 10, and I charge them utilities and a monthly rent because I want them to learn. Like,
Let's
you have to budget,
talk about
you have
that.
to do that. Yeah,
I have an 11 and 12-year-old too. We could take that offline.
Yeah, you got to start charging them rent. That's a great journey.
Yeah, it is. It's a very good journey. And I do appreciate, I like the way that your dad started you early, and you just continued, because as I said, as reading your bio, very diverse in skill sets, backgrounds, experiences, education, even your affiliations with memberships, very diverse thinker and kind of recognizing interdependency. So
I have a follow-up though. I have a follow-up that just popped in my mind, because you do have a lot of letters, and we are a very letter-driven profession.
Yes,
there are a lot of letters in this profession, and we like those letters. And it was interesting because you went down the path of the medical coding certifications. What took you from the certification level and saying, all right, now I want to go get the RHIA and the 4-year degree, and then on to the master's? Because I think about some of the students and the younger professionals out there that may be in a similar boat, and they're trying to identify, do I continue down just the certification path, or do I go into the baccalaureate or master's programs? Any thoughts on that?
Yeah, that's a great question. For me, it was starting out with a skill set, and that was the medical coding certification. So whether that is, the CPC or the CCS or the CCSA, or, just starting somewhere. I started with the skill set of coding first. And then as I began to gain experience there, I noticed that, in order to grow within my career, I needed to branch out, and I needed to understand more of how that certification impacted the healthcare system. So for me, that was going on to the associate's program of the RHIT. And that gave me more knowledge, more insight on, the securities around health information and protecting it. And then as I grew in my career, I understood I needed that bachelorette level of the RHIA, and that opened doors for me to enter into management and to also be a mentor to others. And from there, I just began to add on more certifications as my experience allowed, and, just as I began to grow in those areas.
Yeah, what a great answer. It's inspiring, and also a great path. Start somewhere, right? You just have to take the first step. So starting that way. And then I noticed, that you've moved even outside of HEMA, and you have some other credentials. And it was because of your experiences, where you were in that time and what you had to learn to do your job well.
Exactly.
You learned a new thing, right? You got certified in a new thing. So fantastic. Wow. You should be the poster child for basic growth, because that's great.
It's a great story.
Absolutely. Thanks.
Yeah, thank you for sharing that. So let's get into some of these contentious topics I mentioned in the bio or in the introduction to the episode today. One of the things that we as health information professionals, we've been fighting to, I don't know, maybe we haven't been fighting to keep it because we've let a lot of things go, but we've recognized in the past decade or so that we've probably a dozen years that we've let some things kind of slip through our fingers. And part of that we'll talk about a little bit with meaningful use of EHRs, kind of lost some positioning of the legal medical record oversight to IT because it became function driven from a systematic standpoint. With some of the nurses, we have lost some positioning in clinical documentation. Not that we don't still do that. We do still have a credential in a HEMA. Our health information profession has a credential for clinical documentation. But the contentious topic here is, is there a place in health information in our profession for clinicians? And that could be doctors, nurses, NPs, PAs, doesn't matter, respiratory therapists, doesn't matter what it is, any clinical type role or provider. Is there a place for those folks in health information? And if so, how do you make that union? How does that work effectively and appropriately in a way that protects our profession?
Yeah, and that's another great question and timely question. I'm just taking a look at the industry, and I think that the best way to answer that is to understand that we bring unique perspectives as health information professionals on more of the coding side or health information side. We bring a perspective where we're more so looking at the PHI. We're handling that data and we're using it on the back end to improve patient care. But on the clinician side of it, we have to understand that they're coming with a different perspective as well. They're front end workers and they're seeing a different side of the patient care than what we're seeing on the back end. So understanding that we're bringing value from two very different perspectives and being welcoming of the differences, I think that would help us grow as not only health information professionals, but as an industry. And when I say being welcoming of the clinicians and, those who are on the front end within the health information space, we by welcoming them with their expertise and their perspective and working hand in hand, such as in CDI or with a legal medical record, that would enable us to improve. And for an example, we see that there are differences within the coding guidelines based on real-time patient care and what clinicians are seeing. And we see those gray areas, those discrepancies that are not yet addressed by CMS because there's a translation issue. But having the perspective of a clinician or a nurse that is able to, see the gray and seek out clarification, in my opinion, it helps us just as an industry be better.
That's awesome. So I guess when I'm hearing you tell the story, it's more of a collaboration than it is moving those professionals into the health information profession. Is that what I understand here?
Absolutely. And there's room for both. I'm not saying that only clinicians or nurses are the most appropriate for CDI. We see that there are very skilled HI professionals who they do a good job at the CDI function. One being myself, I'm not a clinician, but I've managed and I've worked in CDI for years and have significant impact, positive impact, and developed CDI programs, built it from the ground up without being an RN. So there's other professionals out there who can bring that value to those type of programs. It's just a matter of collaboration.
Yeah, absolutely. And I definitely agree with you. The well-trained and credentialed health information professional is as equipped to manage CDI the way that
Absolutely.
CDI has to be managed today. Collaboration with clinicians of all, no matter their tier, right? From a lab tech all the way up to whatever the most decorated physician is, right? The collaboration, we should be open to collaboration. So this topic wasn't contentious because we agree. I don't have to ask you contentious questions as a follow-up, I don't think, because what I hear is there's huge value in that collaboration, and there are interdependencies that if we do collaborate, we make the documentation and the story of the patient told more effectively.
Exactly.
Appropriate reimbursement out of that situation based on a true and full story. That includes the money that clinicians get. Okay, yeah, yes. I can see that. I can see that. I kind of thought where that question was going to go was, do we bring all the, because here's a topic for us as health information professionals in our current state with AHIMA. AHIMA in 2023, in the fall of 2023, completed the acquisition of HCPro. HCPro owns Actis, and in Actis, there are tons of nurses. I don't even remember their membership number. Seth, do you remember the membership number?
No, it's pretty
Tens
healthy.
Thousands, right? Tens of thousands. New nurses that kind of brought in under our arm, and so one of the things that we have talked about in just being members is, how do we have nurses should not be representing the health information profession, because the health information profession takes training and skills just like the nursing profession does, and they're separate even though they're interdependent. So this topic turned out to not be contentious. I'm surprised. I thought we were going to have a contentious conversation there. So
go ahead. And I will say that's why I mentioned earlier that it's timely because of that acquisition where we're seeing where nurses, they're brought into AHIMA, and AHIMA is predominantly health information management professionals. And with that being said, we need to start the conversation on how do we become more inclusive of the clinical staff in AHIMA, and how do we welcome and provide resources that are valuable to them as well, to the nurses and clinicians that are joining this larger picture of the health information professional workforce. So I think that's something that we should direct attention to, and have more conversations around of how we can offer those resources to them, just as we've done for years for the health information professionals.
Yeah. Well, it's interesting because I'll take that question a little bit farther. How do we become fully inclusive and offer those resources without watering down the health information profession? Because AHIMA is not just predominantly health information professionals. AHIMA only exists to support the health information profession. That is the goal and the structure and the requirement of AHIMA. So how do we include those folks, the clinicians, nurses, doctors, whomever they are, and be effective at delivering the education or the things they need and fostering that relationship without watering down the value of HIM? That's the biggest question. And I think that we've been struggling with that for a long time. Prior to the HCPro acquisition, this issue did not arise from AHIMA acquiring HCPro. It definitely exacerbates it, but it did not begin there.
I agree. It shines the light on it that it is an issue that should be addressed. The latest conference that I went to in Virginia, that was one of the things that we noticed. We had a higher, we had an increase in the amount of attendees that were clinicians at that conference. And historically, you would only see, health information professionals. So that was one of the things that I thought of. I said, I wonder if they're finding the conferences as valuable as, those who are holding certifications from AHIMA, and in the future going forward, what would that look like for them and how we can be inclusive?
Yeah, I think there's really a place for us. I think there's a place for clinicians because
absolutely.
I married a nurse, so I have to be very careful how we say this. But the way you framed the skill sets of the clinicians being front end focused and the HI professional being back end focused kind of clicked with my brain, right? They understand the daily process, the clinical process. One thing that I hear my wife talk to young nurses about is, yes, you're going to school and you're going to come out of this wonderful nursing education with an RN or a BSN. You're still going to be working night shift. You're still going to be working weekends. You're still going to be taking care of grandma in some of the most, I'll say, yucky situations, because that's the extent of my clinical abilities. And, a lot of folks do that for many years in the clinical space, and they kind of burn out of it, and they want to go do something beyond direct patient care. The HI profession and the subdomains within that kind of open a door for them to bring that experience in and to do something that isn't night shift on Christmas and taking care of grandma in that state. So I like the way you framed that as front end knowledge and skill sets alongside back end knowledge of skill sets. But Shannan wants to get to a contentious subject, so let's get into a contentious subject.
I just it in the conversation.
Shannan wants to fight. Let's fight. Here's the big question. So one of the things. Go ahead, Shannan.
Let me interrupt for a second. So I don't know if you even know this, Seth. Maybe you do. But my, I'm a tech entrepreneur, right? And one of my companies, my title is R squared, founder. And that R squared is for Rhonda Rousey, so RR, because my business partner tells me that I like to fight. So Seth is kind of following along. I think that they have that perception of me. I'm not gonna claim it or project it. So carry on, sir.
That's okay.
This question will be fun because I think it will spark some interesting comments in the comments section, and it's also fun for me because I sit in a global role, so I get to look at things. But Anneleah, in the prep document, one of the questions was, "What are your thoughts on outsourcing revenue cycle management services to global resources versus onshore?" And here we go.
Well, that's a question I believe that many facilities are asking. And, do you go offshore or do you stay onshore? And first we have to understand why is that a topic? Why is that something that's coming to be? And we see that right now, just taking a step back, looking at the industry, it seems to be that there's a gap in the workforce, especially when it comes to coders. We're experiencing shortages in inpatient coders. And we used to have, high demand, but many coders that were just, able to, a large pool to select from. And now, we're seeing this scarcity happening. So what I'm seeing is that there are facilities asking, how do we close that gap? And they're looking at offshore coding. Secondly, looking at skill set. We're finding too that it's a question if you should look offshore due to, lack of skill set that is found onshore, or the ability for resources to obtain resources at a cost-effective rate. So I guess first asking if it's something feasible for the facility, if they could support onshore coders, then that's something that, that they would need to explore. But what we're seeing and what I'm seeing is that offshore is kind of taking the cake due to the fact that facilities are, they're in binds with revenue where they're unable to support onshore coding to that nature. So
it's not just the coding world that's happening in. I live in the technology world, and technology companies are, that's a very common thing, is to have support teams that are around the globe, because you can do sort of a follow the sun type methodology. There's a definite cost savings around it. And what you mentioned there of the workforce gap is very, very true. Many, many years ago, back when all of my hair was brown and not gray and starting to turn white.
I
And
was going to say, I used to see more hair down here.
I can cut it out of certain
Shannan.
spots, but luckily it's unfortunately it's starting to all turn gray and white. But many years ago, I managed the help desk for a health system that reported up through me, and we were starting to see then the challenges of hiring. It was difficult to get folks to want to work night shift on a weekend to do help desk calls and to have that skill set that we needed to be able to answer the calls. But at that time, and then you add on the fact that this country's very expensive, right? It's an expensive country to live in. It's an expensive country to operate in. So the wage requirements are very high. So there is a gap that is in the workforce for, I don't want to call it entry level, but that tier 1, maybe even tier 2 support, whatever the industry may be, where offshoring does have a place. It does play a role. And that's
It
something
really
that
does.
in the technology world that's there. And I assume that's the same in coding. Is that a fair assessment?
It is. It is. And what I would say to the facility that is entertaining or exploring offshore resources is to several things. You want to first ensure that there is a compliance education program set for the offshore team. You want to make sure that their skill set, their education, that they're able to perform at the level that we see that the onshore coders are performing at. So making sure that there's compliant training intact, that's the first thing I would recommend. Secondly is making sure that there's a robust audit process, that there's a regular routine audit that is going on to ensure that the offshore team is in compliance with the training that was given. And then lastly, I would say just making sure that there's an environment of transparency and open communication, lots of reporting, and just so that the onshore facility has, they have visibility into, what the scores are looking like, what the metrics look like, and even the quality of the work that's being done.
Yeah, some of the things, Annaleah, I noticed, in your bio, you've done a lot of work in rural health. And in rural Tennessee, rural health is definitely rural populations, and women are the populations that I want to uplift. Like, that's definitely where my heart is. It's a natural thing for me. And in rural hospitals, hiring skilled coders has been a challenge for as long as I can remember. And
Yes.
maybe for, the outpatient coding for diagnostics, things like that, pretty simple, straightforward. You can bring in a high school diploma person and train them on that outpatient if you're in a rural place, because you're only doing those routine things. You're at critical access or rural hospital. You're not a trauma center. Most of us are not doing obstetrics anymore, right? We're just, unless it's in an emergency situation, we're just stabilizing and transferring so many people. But beyond that, for outpatient surgery, even for emergency room and inpatient, it's definitely been a challenge for many years to find coding staff that is qualified to do the work. I also think the gap, the shortage that we have is a challenge no matter the type of organization, whether it's a large health system, a level 1 trauma center, a women's specialty, cancer, it doesn't matter. The coding is a challenge for sure.
I agree.
And I think one of the things that I have found in my rural hospital experience, and I want to ask you if this is the case for you, I find that those rural hospitals are less willing to hire remote coders, which is where their talent pool is. If
Exactly.
So it's almost like if you were working with a critical access or a rural hospital and you were they ask you to consult and help them find a remote, an offshore coding company to work with. And I'll get to all those challenges in a minute that you mentioned, but can we start encouraging those folks to go remote first for the sake of this existing workforce population in this country before we move to an offshore. Now, I do recognize there are cost differences with, remote workers here versus offshore staffing. I understand that. But I don't even think a lot of the rural facilities that I have an experience with, they are not willing to hire remote. Do you find that to be the case?
That's been my experience as well. And I wonder if it's, or my thoughts, I think it's because of maybe technology limitations that prevents them from allowing their coding resources to work remotely. But I do know that that would definitely open up their workforce pool if they were to, explore the potential of remote work. And then secondly, when the conversation did come up in my past time with working with rural hospitals about global workers, there were concerns about if their technology would support the global coders in the sense of like have the proper safeguards and security in place. And that was a valid concern for many of them, that they didn't have the proper technology. So that is a real issue that's going on in the rural community. And, definitely something to have a conversation about is first, how do you address with the onshore coders opening up the doors for remote work? And I believe that that would open up the workforce for them. I remember going to a community hospital or a rural community hospital in Texas, and actually training the nurses on, coding guidelines, because they didn't have any coding resources. So just trying to give them the most that I could before leaving, just so that they can have what they needed to run operations. So it is a real concern that we should have a conversation about.
Absolutely. And I think too, if you're able to provide technology for offshore, then you could certainly provide it for onshore, right? I mean, you should be able to open up your talent pool here if you're able to open it up globally.
I agree.
Another thing, I have a question, and this might be as much for Seth as it is for you. Both of you, though, are tenured professionals, and we've been here for a long time. A few years ago, several years ago now, HIMA had a very heavy focus on training coders in other countries. I believe we did a huge thing in maybe Saudi Arabia where we were training coders there, which I support, by the way, fully support training coding staff to, even if they have different guidelines, training them on the principles of coding for ICD, whatever version, right? Just training them for what coding is, what it means, and how we do it. The question for both of you is, with the chicken and the egg. Did we have all of this offshore opportunity from a diagnosis and procedural coding standpoint because we trained coders on other continents, or did we pull them in because we had our shortage here first? How did we get here? Where we have that availability in other countries. That's my first question. And the second is, I know just from the communities that I'm involved with on a global technology standpoint, some of the entities that have approached me about introducing them into American healthcare systems so that they could bring their coders and their scribes and their different, whatever they have, medical assistants and receptionists and the whole everything. No, none of them are certified. When I ask about certified coders, they said yes. And so then I said, okay, is it AAPC or a HIMA? And they're like, huh? And I'm like, no, sorry, not. Go back. Here's a link to a HIMA. Go get your people certified, and then you come back to me, right? So you have to consider that. What you're bringing from offshore, are they actually coding certified, and can you check their status? They're not. Most of the time.
Many of them are not. Yeah.
And that's a problem, because even if you're filling that role with a coder and somebody's actually doing the work, you have no idea what the quality, which probably lends itself to the quality discussion you had a moment ago. But if you've got to do that much work, wouldn't it be better to pay a little higher onshore to not have to do so much operational churn?
You would think, but due to, I guess, every facility is different and they have to do an analysis of what the feasibility is, what the financial opportunity is for using offshore versus onshore. Offshore is just a fraction of the cost of what an onshore coder would cost. And back to your chicken and the egg question. Interesting thought. I think as far as like, did we bring them into the American health system, or did we create the gap here? Like, where we're in need of offshore coders. I don't really think so. I think the code set that we use is international. So there are other countries that utilize the code set, for their health systems as well. And healthcare is everywhere. Healthcare is, it's a need that's not going away as long as there's human existence. So I think, as you mentioned before, how AHIMA I don't know if they still do offer that education to other countries, but I think that, global coding is something that's probably not going to go away either. And it may be for healthcare organizations such as AHIMA to, take a more robust approach to educating in those areas so that we can see more uniformity.
Yeah.
I think the technology outpaced the training is what, in my opinion, the technology became available to make this something that we can do quite easily technologically. And then the opportunity blew up around the world going, hey, I can set up these companies in these different areas and staff this for, as Anneleah mentioned, a fraction of the cost.
Exactly.
But then we get down the road and it's like, well, now I'm struggling to develop the training programs to level up those folks to meet the expectations of the US-based healthcare system. So I think the technology outpaced the training. And while AHIMA was doing good work, it was in pockets, and then it wasn't a global thing. So I think a lot of the companies that are out there I know we have several THIMA members that travel globally and do some training programs for their offshore pieces. I think the market had to shift and train their people and sort of encapsulate what they were hiring offshore in certain regions and focus the training efforts there, because the technology's done. The technology's easy. Then the question becomes, all right, let's future focus this into AI. How does AI shift? Because AI really does well at the entry level positions, the entry level job duties. So how do we elevate AI into that and utilize that onshore and elevate our folks, skill set them up to be able to manage the AI engines and keep that aspect on
That's
onshore?
Interesting. Yeah, that's interesting. The thoughts of AI here, because here's the biggest thing. And Anneleah, I appreciate you mentioning the global ICD. ICD is a global, data set. It's a global structure. The difference is we have a different type of healthcare system than almost every other country in the world who have government funded or public options, where ours is a private. Now I understand we have some payers that are, we have some Medicare and Medicaid, but it's not the global, it's not what our whole national healthcare system is. It's a very different setup. So we had Dr. T on, Jason T from Asia, and the coding there is very different than here. Here, we use coding to drive revenue more than absolutely anything. I mean, it's important to research, and we started collecting because of research, but as soon as we had a meaningful use case where we were collecting for reporting prevalence of disease and such, we started tying all these revenue components to it. So even if you have global coding training, there has to be almost a country specific coding guideline and rules training, which, Seth, to your point, I think the leveling up of AI training there could make a difference, right? Because you could say, okay, now take the global training of ICD X and apply the US coding guidelines, or apply, the practice in Asia or whatever it is, right? Or the many countries in Asia, because they're different too. They have a different rate of adoption of technology, of standards, of all the things. So it's a challenging question. Do we need a lot of additional coders? Absolutely. Should I, as a member, expect AHIMA to address and meet that challenge? Absolutely. I think I should, because we are the rock stars of that. Can they do it at a pace with which it will meet the supply and the demand? I don't know. I'm not sure.
And I think that's what Seth was alluding to, is how it became more encapsulated, where it's more of it's the responsibility of the market, so to speak, to catch up educationally. And I like the idea that there are certain members who are going out to teach their offshore teams, and I think that's probably where it needs to start. And then, perhaps it'll get taken up, or the larger organizations will pick it up and continue the trend.
Yeah, absolutely. Well, Anneleah, thank you so much. What a fascinating conversation to consider. I like that we're doing this toward the end of the year. So for anyone out there who is a health information professional, or if you're not and you're listening, coding from the AHIMA standpoint is a place that we still have the need. I know a lot of people are fearful that AI will take all those coding jobs, and AI is making coding more efficient. We will have to have auditors looking at what AI does, so it's never going to go away. So if you're a coder, think about these things. Could you create education that helps onboard coders for your organization that are offshore? Could you create something in place that automates so that you don't have that operational churn? If you are training them up in the beginning, then you can be on a regularly scheduled audit process like you are your in-house staff that codes, right? Think about the opportunities to do global work from training different countries. There are definitely opportunities here. So while this last topic both topics I think can be contentious, there has to be a solution where we're still in the lead for these things, but it doesn't mean we don't welcome in alternatives, right? But we need to be the leaders in that. And I think I would not have a contentious feeling if I felt like we lead still in all those places. I think I would be much more supportive of the movement.
Yeah.
Well, thank you so much, Anneleah. It was a great conversation. And I'm so impressed with the diversity of your skill set and your activity, like all of your active membership, and that you lead in your states. What is your current volunteer role elected?
I'm the president for 2024-2025 of VHIMA.
Yeah. And so constantly leading, constantly learning, constantly inspiring. So it's been amazing to have you on. I'm very thankful that we got to meet you, because I don't know if we would have met you outside of this, and you're phenomenal.
Yeah.
Thank you. It was such a pleasure to be here and to meet you all.
Yeah. Thanks again. And we'll be working with you, I'm sure in the future, because that was a fun conversation. And with Virginia and Tennessee being right next to each other, I'm sure we'll run into each other at the component association items. But thanks again. And Shannan, until next time, my friend.
See you next time, buddy.